The following podcast is part of a certified educational activity titled Adopting Telemedicine and Digital Tools for Non-Valvular Atrial Fibrillation Management and Stroke Prevention. Access the entire activity and complete the post-test at peerview.com/TWX860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Khaldoon Chourakchi. I'm an Associate Professor of Medicine and Associate Section Head of Cardiac Electrophysiology, as well as the Director for the Center for Digital Health and Telemedicine at the Heart and Vascular Institute at Cleveland Clinic in Cleveland, Ohio. Welcome to this educational activity on adopting telemedicine and digital tools for atrial fibrillation management and stroke prevention. Joining me in this discussion is Dr. Rod Passman. He's the Jules Reingold Professor of Electrophysiology, Professor of Medicine and Preventive Medicine, Associate Director of Cardiac Electrophysiology, and the Director of the Bloom Cardiovascular Center for Atrial Fibrillation at the Northwestern University Feinberg School of Medicine in Chicago, Illinois. Welcome, Rod.
Thank you. Thank you very much for having me today.
Well, Rod, today what we hope to touch base upon is how technology is transforming the way we provide care, especially for our arrhythmia and specifically atrial fibrillation patients. Technologies have transformed many aspects of our lives, whether it's the way we listen to music, the way we do our shopping, the way we do banking, education. The one thing really that has not changed much is the way we practice medicine, specifically in the outpatient setting. Now, the concept of providing this type of care virtually through telemedicine is not new. We know that we've been providing care for astronauts. Yes, we might be behind adopting this technology in healthcare, but the concept has been there. Whether it's astronaut in the space, whether it's area of natural disaster with the Red Cross dispatching teams to provide care remotely, or in rural areas. But that needed the muscles of big organization or the government to accomplish this. It was not really widely available. But more recently, in our recent past, we've been providing some models of remote care specifically for the arrhythmia patients through implantable devices. We have millions of patients with pacemakers and defibrillators, and we've been doing remote monitoring for these patients for decades now. We just never gave it the name of telemedicine at that point, but it's truly part of our gene, part of our daily work that we do for our implantable device patients. But the newer models of providing care remotely through real-time audio-visual technology, this was only made possible by the advancement in technology, whether it's the broadband internet high-speed connection, the availability of high-resolution cameras. Everybody's walking through with smart devices. None of this was reality 10, 15 years ago. And we tend to forget this. While the desire was there to provide these opportunities through telemedicine, the reality is we did not have the technology to support it. Now, the reason as a community we're excited about telemedicine because of the promise that it will overcome geography, time barriers. You can actually have better access to care, whether to your primary care physician or to some subspecialties as well. Convenience is something that we all seek and try to achieve, and also cost savings. And cost savings does not just mean the actual cost of the visit, but also time from your work, time from away from your loved one, driving and parking and travel. However, we're very mindful about the challenges that we had and continue to have to some extent. We really needed a reliable infrastructure, and that platform was not widely available to many institutions. And that goes both ways as well. Patients, do they have the right internet access? Do they have access to a device with a camera? We provide care for everybody and not just a select few, but obviously the trend is to more wider adoption, and this is where we're heading as technology becomes cheaper and more widely available. We only also had limited adoption by our colleagues and not just by patients. At the clinic, for example, Rod, I think when we looked at data before the pandemic, about 20% of all our staff members accounted for 80% of virtual visits. Again, to show you that it was still limited to the few and not everybody, even as in the medical community. And the same thing applies to different institutions with adoption of virtual visit. And obviously, the top concern in the mind of clinicians pertaining to telemedicine adoption is the uncertainty about the rules and regulations and the reimbursement models. So for us, for example, at the clinic, we've been doing virtual visits even before the pandemic. And Rod, this is an exercise that we did, and the reason I'm proud about this study because it really preceded the pandemic. And we wanted to seek the feedback of our patients who were scheduled for a follow-up visit using virtual visit as opposed to in-person visit. And we learned a lot of lessons. I think the one most important point, which I mentioned it before, 9% of the patients who were scheduled for virtual visit could not complete it because of technology issues. Again, to show you, while the desire is there, are patients ready? Do they have the right internet speed? Do they have the right device? Oftentimes, we turn as physicians at tech support, trying to navigate how you can use that system. But when it's done successfully, this is the feedback that we got. The overall satisfaction was excellent. They were able to communicate with the physicians. They got the physician that they wanted to see. They were able to even share some data from their remote monitoring devices. And the overall satisfaction was excellent. There's one column that stands out as being suboptimal in the performance, which is the payment model. Payment was an issue, and again, this is before the reimbursement for these visits. And to show you that we needed some guidance and rules to help us with rules and regulations. Now, as far as the technology is moving at a very fast speed. It's there for us to use it. Patients are quick to adopt these technologies. Oftentimes, they come to you with these devices and wearables that I hope you can talk to us a little bit about today, Rod, as far as how we can use these devices with gadgets and wearables to our advantage. So they are quick to adopt them, and it's not unusual for them to come using these devices. For us as a medical community, we are a bit slower to embrace and adopt and learn about these technologies, but we are moving there. And finally, we do need guidance from our professional societies. We need better rules and better regulations and clear reimbursement models when it comes to wider adoption to both telemedicine and all the digital health tools. Now, we have a big footnote that happened, which is the pandemic. And to me, the pandemic was a wake-up call, and really a lot of institutions with a crash course in how can we adopt this technology at time of crisis. So what happened in the COVID era? CMS, commercial payers, and the government, they were quick to respond, and they acted at unprecedented speed to dramatically increase access to telemedicine, given the circumstances. It was truly a crisis situation. So what happened? The coverage was expanded, so it's no longer limited to rural area, but also covered urban areas. It covered new patients as well as established patients, which is a huge change. And again, back to the issue about the platform, because not all institutions had ready-to-go platform. They actually allowed different platforms to be used for the audio-visual connection, and they matched the payment for virtual visit to the in-person visits. And there was a temporary waiver for in-state licensure requirement. Again, I think this is a response, and I hope you agree with me, Rod, that this is really a crisis time response. Unlikely to go back to the old times, but I'm sure it's not going to look the same as we move forward, hopefully beyond the pandemic.
Yeah, I agree with everything you're saying. And one point I want to emphasize was that when I first went to telemedicine, I thought that the patients were not going to be satisfied with that interaction. What I found is exactly what you said, is that I actually spent more time listening to the patients, speaking with them. And I think patients really appreciated the time that you spent. Clearly, again, there are some situations where seeing them in person is invaluable. But the other big issue is that, for a subspecialist, it may take a long time for a patient to have an appointment. And often I could see people, with very, very short notice and attend to their immediate issues. So actually our patient satisfaction went up when we shifted to telemedicine. And I still today have patients who probably could come in, but for work purposes or just how far they live from my institution, prefer telehealth over an in-person visit.
Yeah, absolutely. And to show you the impact of these changes and rules at time of crisis, I think this is very evident in this slide to show you in the solid line the rate of change in telehealth encounters between 2019 in 2020. And as you can see, this is when the first US case of COVID and all the changes in rules and regulations. And you can see the dramatic increase in the rate of telehealth encounters versus in the dotted line or the dashed line, you can see the percentage of change in emergency department visits, for example, something that was really of a big concern to a lot of us. Where are all the heart attacks? Where are all the strokes? People were afraid about coming to the emergency room. But it's really a true testament about how this crisis management reaction made a big difference. It was really something that we all needed at time of the crisis. So I wish I have the crystal ball, Rod, to predict how the world of telehealth is going to evolve. I personally think there's a silver lining of all what happened. For example, I can talk even internally at our institution that telemedicine is certainly has gone from being an exotic way to deliver care to an expectation from our patients, from our nurses, from our colleagues. But there are many keys for successful telemedicine program. Let's move beyond the crisis situation. Let's look about how you build it. Let's not repeat the same mistakes. And few points that I would like to share with the audience today, and Rod, feel free to add to this. Most importantly, you need a reliable platform that usually happens from your organization. And even the platform can have a lot of enhancement, including inviting a family member to join, for example. A lot of these platforms now are embedded in the electronic medical record system that you use, avoiding the need to go to third-party websites, downloading additional apps, etc. But you really need to engage all the stakeholders. It's not just about myself or Dr. Passman. It takes a village, and we've been trying to build this before and certainly moved forward with the pandemic. And those stakeholders include your nurses in your outpatient, your schedulers, your administrative assistants, your legal team, your billing team. Things are changing at a very rapid pace, and you really need to stay informed and share that knowledge with your colleagues in your institution from one source to stay up to date. And one thing that I truly feel passionate about is you need supportive tool. I think there's a lot of advantages of seeing the video conferencing. Seeing the patients is priceless. So that by itself is a big difference than just a telephone encounter. You see them, you can look them in the eye, you can appreciate some limitation, both physically and emotionally. You can talk to them directly, but it still lacks the data. And to have the data to support your virtual visit, we have an advantage of all the tools that are coming to us that Dr. Passman was mentioning about. So these are a few points that we learned over time, especially as a crash course for a lot of us during the pandemic. I don't know, if Rod, if you want to add anything else for a successful program about who else to engage in that program.
Well, I think you raise excellent points here, and I echo your sentiment that medicine has sort of been slow to adapt to these changes. But I do think that while there are challenges, this creates great opportunity. It's great opportunity to provide more immediate care to patients, regardless of where they might live or what their work schedules are or their other responsibilities at home. And I do think that we need to really look at this as an obligation to patient care and think that the visits and the old paradigm of coming to the hospital only either when you're sick or when you have a scheduled appointment is going to change. And we should be leveraging these advances to create and support these opportunities. But I think, the reality is that we need to understand how we monetize these, how we get this data efficiently into the medical records. And for that, you do need to engage all of the stakeholders that you talk about. And often it takes a champion. Sometimes it's not an administrator who sees the value here. Sometimes it's an individual physician that drives this forward, or a nurse, or some other person who sees the limitations in the current model.
Yeah, you said it beautifully, and champion is actually the exact word that we use in multiple sections to transmit the data or stay up to date. The other point that you mentioned, we have to be responsible. I mean, these are great opportunities, but also we have to address all the issues from patient standpoint, their comfort with technology, social justice, but also it applies here as well as far as having the tools to make this happen. And I think we desperately need to measure outcomes, and it's probably a responsibility that we all have we did a simple exercise on a small scale in one center, but moving forward, I think as a community, we do have to make sure that we assure quality, address patient satisfaction, just like we do in person. Doing it virtually, we have the same type of responsibility. And perhaps a point that I mentioned before, and I repeat here, that virtual visits should not be just a glorified phone conversation. You have to support it with tools. You have to have the ability for patients to share their data efficiently in a meaningful way. And that actually takes virtual visit to a completely different level, not only to make it equal, but frankly, in our specialty, a lot of times even better quality than in-person visit with one single data element. And that's something that we're probably at a big advantage in our specialty, especially when it comes to atrial fibrillation management. And what I hope that with you, Dr. Passman, to share with us just an overview about atrial fibrillation. Why does it matter? And what is the landscape of tools that are enabling all of us cardiologists and electrophysiologists and internists as well to use these tools to our advantage in the care of the atrial fibrillation patient?
Right. So let me just get Khaldun's. I think that the data is pretty clear that the treatment is going to be probably better if this is taken care of by a specialist or subspecialist. So my feeling and my bias is that these patients should be generally seen by cardiologists at the minimum because they're much more likely to get an effective rhythm control strategy. But I also don't want to alienate your maybe rural PCPs where that's not an option. So Khaldun, do you think we'd come down strongly and say, in the modern era that there's pretty good data that, effective rhythm control might be an option, and often these patients may benefit from being seen by a cardiologist or a cardiac electrophysiologist. Is that fair?
Back to your point, it's always mind-boggling to see somebody who went to the ER and they had AFib, and they send them to see us without even starting anticoagulation. Like, why don't you start at least the minimum? And something I think Rod mentioned that probably the most course of action, everything else can wait for a short period of time, but there's no reason not to be comfortable of initiating at least a discussion about stroke prevention.
But I think maybe what we should do is, where the PCP fits in. So I think that, the expectation should be that we're going to give anticoagulation, we're going to give some rate control, we're going to order some tests, and then send you to a cardiologist so that when he or she sees you, they'll have those results and can take better care of you.
Got it. Okay. And in my mind, Rod, I always mention this, that a virtual visit should not be just a glorified phone conversation. We gain a lot from seeing the patients. I think looking at at them through video, it's a huge advantage compared to telephone visit. But it's not mission accomplished until you also support it with some data. And again, this is when all the digital health products, the consumer products, when you go through the process and build a workflow, they can be a huge asset to transform the care and take your virtual visit to a completely different level that could be better than in-person visit supported with one data element, for example, with one single ECG. Any thoughts, Rod?
No, I think I want to highlight what you said, that the technologies that we're going to be talking about really just aren't a substitute for an in-office ECG. They really take it to the next level, right? Where for the first time we could monitor patients, for an indeterminate period of time, record their rhythm, when they're having symptoms, when they're not having symptoms. So this isn't just a substitute for what we do in the office. This is really a whole new ballgame.
Yeah, that's great. So, Rod, look, atrial fibrillation is in the mind of everyone. It's obviously the most common arrhythmia in the world. And tell us a little bit more about atrial fibrillation, why it's important to diagnose AFib, and also educate us a little bit about the landscape of all the tools that we have. Some of them are more traditional tools, and the new wave of new tools, specifically consumer products, that could help in the management of the patient with atrial fibrillation.
Khaldun, thank you for that outstanding introduction about telemedicine. And as you mentioned, we in the electrophysiology and cardiology world have been somewhat fortunate that we've had tools for a while that we can measure biological parameters for our patients. And we've been using blood pressure monitors that you can get from your local pharmacy for long periods of time. And most of us have been aware of the ability to record a single or now multi-lead EKG for the last few years. And I think this is a really invaluable tool that can be of use not only to heart rhythm specialists like you and I, but really to anyone who takes care of any patients, particularly adult patients who are prone to these abnormal rhythms. So I thought I would sort of go over the general landscape of atrial fibrillation, which is the most common sustained arrhythmia in adults, and some of the available tools that we have available to define and measure this common abnormal rhythm. So for the sake of background, as I mentioned, this is not only the most sustained arrhythmia in adults, it's estimated that this may be prevalent in maybe 5% of the population over age 65, and probably at least 10% of the population over age 80. And I say probably because this disease is often asymptomatic, right? Patients don't know they have atrial fibrillation until sometimes you discover it on a routine exam, or they're getting a pre-op EKG for some other reason, or unfortunately, as I'll mention later, they present with stroke, and that's the first manifestation of the disease. So it's estimated that because of the aging of the population and the growing pandemics, not only of COVID, but of obesity and hypertension and diabetes, that the number of people with atrial fibrillation could exceed 12 million by the year 2030. It's estimated, in fact, if you're a 40-year-old male or female, and you're fortunate enough to live till the eighth decade of life, that your lifetime risk of developing atrial fibrillation is about 1 in 3. We know that there are devastating consequences of atrial fibrillation, but nothing more devastating than the risk of stroke. Atrial fibrillation is associated with a 5-fold increased risk of stroke, and it's responsible for about 20% of all strokes. As I previously mentioned, stroke, unfortunately, is the first manifestation of atrial fibrillation in about 25% of patients. But even those that don't have strokes, we know that atrial fibrillation increases the risk of congestive heart failure, dementia, and those with atrial fibrillation tend to have a higher risk of premature death compared to those without. So we have been living since the last 60 or 70 years in an era where we can record the rhythm of the heart outside the hospital setting. Many of us know the name Holter. There was a Norman Holter who invented the Holter monitor in the 1950s. Unfortunately, the device weighed about 85 pounds and can only record the rhythm of the heart for 24 hours. We now have a whole slew of different AF monitoring techniques, moving from left to right to sort of the Holter monitors that you're familiar with patches on the body and a device that you wear on your belt. There are types of event monitors where when you feel a symptom, you could put this device up to the chest. And then in the far right, something called a loop recorder, which the patient would be asked to warn for 30 days, and the patient would activate and record the ECG only during symptoms. The truth of the matter is that these are cumbersome, and the longer we ask our patients to wear these devices, the less likely they can be compliant. Many people have reactions to the tape on their body, and for multitudes of reasons, we've always been looking for better ways to monitor. If I'll draw your attention to what we call the second generation of external ambulatory ECG monitors, if you look at the diagram on the left, I think is the technology that most of us feel is sort of the easiest to prescribe and patients like the most. It's this patch technology that continually records the rhythm of the heart, and a patch can last for a week or two, and then the patient sends in the device and we get the results of the continuous recording. There are these devices that allow for what's called mobile cardiac outpatient telemetry, where if patients have an event, it's noted in near real time, and that might be more suitable for patients who you believe are at higher risk. But certainly in my practice, I use a lot of this patch technology because I'm not interested or not set up for outpatient management of serious arrhythmias, for which patients should probably be in the hospital if your level of concern is quite high. So not only do we have these sort of wearable technologies that we have prescribed in the past, but we've also recognized for probably the last 20 odd years that implantable devices can be used for arrhythmia monitoring. And that technology was really developed in pacemakers and defibrillators with wires or leads in the atrium that could record all episodes of abnormal rhythm. And in its earliest iterations, patients would have to come to see us to get that data downloaded. But since then, we now have device technology where the patients can remotely download their device. And in fact, these devices can be set up to automatically download if an abnormal rhythm, including atrial fibrillation, is sensed by the device. And on the bottom left is a device called an insertable cardiac monitor. These are devices that were initially the size of a computer thumb drive and are now the size of a large paper clip. And in its current iteration are small enough to be injected underneath the skin by the left of the sternum. And these devices also continually record the rhythm of the heart, though without a wire inside the chambers themselves, and every night can download that information via a transponder by the bedside and tell your study center or your clinical center that your patient is having an abnormal rhythm. So the ability to remotely monitor patients for abnormal rhythms, particularly atrial fibrillation, has been there for a while. Of course, the problem is, or the reality is that most patients have no indications for implantable pacemakers or defibrillators, and implantable monitors are invasive, they are expensive, they require a vast infrastructure to receive the data and adjudicate it and respond to the patient in a timely manner. And all of this technology thus far is really physician-facing, right? We as caregivers are the ones that get the data and then have to get back to the patient with the results, right? What we really need are inexpensive consumer-grade devices that tell the patient they're having an abnormal rhythm and that the patient could share that information with their caregiving team. So the devices I think that many of us are familiar with are these handheld single or multi-lead ECG devices that can essentially turn your smartphone into a EKG machine. So the device I'm showing you here on the far left is a single lead device. You put your fingers on these sensors and it records a 30-second ECG. And it will actually read that ECG as normal rhythm or possible atrial fibrillation or indeterminate if it can't tell the difference. And patients can actually send a PDF of this tracing to their healthcare team. On the right is a similar device, but instead of just putting your fingers on the sensors, there's a sensor on the bottom that you put on your leg, and it records a 6-lead ECG. Again, very valuable and can be sent to your healthcare team. You can buy these online. It's sent directly to the individual, and it requires no prescription. But that is still a snapshot in time. And Khaldoun, I'd like your input. I mean, where would you use a handheld device like that? What are common scenarios that you think that this is most useful?
Yeah, no, this is great, Rod. And I apply certain rules in my brain when it comes to any monitor, including the traditional ones that you mentioned at the beginning, and this new wave of wearables coming to us. And a few questions that I immediately ask. One is symptoms or no symptoms. Are you trying to document an episode when the patient is having symptoms, or are you concerned about some arrhythmia that's happening without causing any symptoms? If the patient has symptoms and they are infrequent to the point that it's probably going to be missed by a Holter 24 hours, I think these tools are great because we're all attached to our smartphones and smart devices. The patient will feel something abnormal and they record. I mean, how many patients do we have that they keep going back and forth to the emergency room just to catch one episode of arrhythmia, and by the time they get there, the episode is gone? So symptoms, frequent enough, but not frequent to the point it's every day. I think these tools will be extremely helpful.
Yeah, I agree with you. And while we're talking about atrial fibrillation, you raise a very important point. You know, palpitations are a very, very common complaint. If your practice is like mine, many of these patients have gone through extensive testing, extensive monitoring, which shows nothing. Well, it shouldn't be a surprise it shows nothing, because if your palpitations occur once every 4 months and you wore a monitor for a week, a negative or normal monitor doesn't mean that you don't have a true cause, arrhythmia cause of your palpitations. So this is invaluable even for that common complaint, and I'm sure your practice is full of patients just like mine where an extensive evaluation showed nothing, and they have their episode and they record a heart rate of 200 beats per minute, or they record PACs or PVCs, or sometimes they record sinus rhythm, which is also quite important. So while the focus today of some of these talks and a lot of these devices are designed for AFib, truth of the matter is they have a really great utility in much more common complaints of palpitations. Do you agree, Khaldoon?
I completely agree, and I think a lot of times by the time they reach out to us, or by the time they are in your clinic, they've already gone through months and years of trying to figure out what's going on. We have patients that were dismissed as panic attack and anxiety attack, and lo and behold, they had atrial fibrillation. And I think the reason this is relevant, because this is not just limited to our specialty, but also the people who are usually the first line, and those could be family practice, internist, hospitalist. So there are a lot more folks who are on the front line more than just electrophysiologists.
Yeah, I agree. So I think, the greatest use of that technology is for people where they have symptoms, and that symptom sort of alerts them to grab their phone and to open up the app, and that might take a few seconds, and then record an EKG. But as I mentioned earlier, with atrial fibrillation, that's an issue, right? Because a lot of atrial fibrillation is asymptomatic, and even people who believe they feel every episode are often feeling only the tip of the iceberg. So the phone might be useful, but really what we need in that situation is sort of a background passive monitor, right? Something that's continuing to check the pulse throughout the day and alerts the patient when their pulse is irregular. And for that technology relies on something called photoplethysmography, or PPG. And this has been around for a really long time. In fact, obviously the first descriptions of atrial fibrillation preceded the development of the ECG by hundreds of years, right? Atrial fibrillation, or the irregular pulse of AFib, we didn't necessarily know what it was described by pulse palpation hundreds of years ago. And the ability to understand what the heart rate is by shining a light on a pulsatile structure has been known for decades. So the current generation of workout wearable devices, including smartwatches, take advantage of this light. And basically, if you've noticed, if you have one of these devices, there's this green light that comes on when you're working out, and that may come on throughout the day. And by shining this light intermittently, the device can tell you whether your pulse is regular, right, or whether your pulse is irregular. It doesn't tell you why it's irregular, but it can alert the wearer that not only what your heart rate is at the moment, but it can alert you as to whether the pulse, as I said, is regular or irregular. And there are several of these devices. We know about the Apple Watch, but Samsung and Fitbit and many, many other devices are coming to the market that combine these technologies, right, that allow you not only to record an EKG, and these devices, by touching the stem of the watch, just like with your phone, can actually record a 30-second ECG and read it as normal rhythm, atrial fibrillation, or inconclusive. But the watch can actually exist in the background and give you a warning that you're having an irregular rhythm and alert the patient to record a single or multi-lead ECG. So here we have an ideal system, right? We have a passive surveillance system that looks for abnormal rhythms and allows the patient to confirm or reject the presence of atrial fibrillation in real time at home without the need to go to an emergency department or doctor's visit. Khaldoon, how has this changed your practice?
Yeah, I mean, this is the beauty of technology, because it's really combining two features. I mean, if the patient is having episodes but they are not aware about, they need a nudge that, hey, go ahead and record. Something is not right. And to me, that was great. The other thing that is important for us in our specialty, we need to understand what we call burden. In a full year, if you're going to record only the 2 episodes of AFib in 2 days, is this it, or are you having AFib every single day? And it's hard for somebody to keep recording, but this can potentially provide a little bit of assessment of what is the true burden of AFib, which might be relevant as far as what other interventions you might need to do.
Right, I agree. Now, I would say this, that, this does what that smartphone adapter does, right? You could record an ECG. What's a disadvantage? Well, these tend to be more expensive, and some people don't want to wear one of these types of devices. And I think that is a limitation, and not everyone owns a smartphone. And for some of these devices, you do need to own a smartphone, and the watch is not a standalone. So those are some of the impediments to these devices. But I think that between these wearable continuous monitors and the smartphone adapter that we showed, I think it's a pretty good overview of what the capabilities are of these devices and how important these are to the management of patients with known or suspected rhythm abnormalities. So I sort of alluded to this, and this is by no means a complete list, but I would show you this, to let you know that this was made about a month ago, and this has probably changed even since that time, right? This is such a rapidly exploding field, and there are devices out there that are not included in this list because it keeps on evolving. So I show you this because there are devices that you could only record an EKG from, shown here on the far right. And there are devices that only look at PPG or photoplethysmography, generally as workout tools, right? And lots of companies have designed a very, very accurate heart rate assessment tools meant for athletic use. And then there are devices that combine the two. So the watches I showed you have that passive PPG monitor with the capability of recording the ECG. And I show you some price ranges here. And again, this is an explosive area, and I'm sure this will change in a month or two. But this gives you a sense of maybe what is best for any particular individual.
Well, Rod, this is great, and it's really what you shared with us now is a knowledge that even us as electrophysiologists are trying to learn every single day. And from what I learned from listening to you, atrial fibrillation is almost a chronic condition that goes through stages. Now, the first one is you got to establish a diagnosis. Then you have to manage that patient. And they require a lot of follow-up. So maybe it will be helpful to challenge you with some clinical scenarios, and maybe you can walk us about, well, how do you approach that patient who's using these technologies, and what is the best course of action? So let me start with the first case. So let's imagine I'm a 65-year-old woman, history of high blood pressure. I'm having symptoms. I'm having palpitation. And I got this, I saw a commercial about a smartphone ECG, so my son went ahead and got one for me. And Dr. Passman, what do I do? This is what I'm seeing on my smartphone. What should I do? Guide me through that process, Rod. What exactly is going through your mind?
Well, first and foremost, remember that while the algorithms that read these tracings are actually quite good, it still requires physician overread because we have countless examples where the computer overread on your watch got it wrong, right? Where it said it was AFib and it was noise or PACs and vice versa. So I think, you need to lay your own eyes on it. And this EKG clearly shows atrial fibrillation. There's no clear P waves. The RRs are very irregular. And while it doesn't give a rate, you could tell that this is very rapid. The spacing is normal, and my guess is the rate is probably in the 120s or 130s on average. So I think that the approach to this individual is they have atrial fibrillation, right? They've had palpitations in the past. Here you've recorded an EKG showing atrial fibrillation, and our society says is that you need a 30-second ECG showing AFib to give the diagnosis. So the diagnosis is clear. We mentioned before what are our major concerns, and I think we would all agree that stroke is the major concern. So the first point I would say is, what is this patient's risk of stroke, and do I need to intervene to try to reduce that risk? Because everything else, to me, is secondary, and stroke prevention is of paramount importance. Khaldun, would you agree?
Absolutely, and that's... I divide them into buckets of discussions, and probably the first one I start with any newly diagnosed AFib is the risk of stroke and ways to minimize that risk and what exactly we need to do. 100%.
So we're going to talk about this woman's stroke risk in a moment, but I want to put that aside because the stroke risk isn't going to make her feel better, right? And is not going to get to the underlying cause. So then the next question becomes, what am I going to do to make her feel better? And for that, you need to talk about, whether we're going to control the rate, and I think we should definitely give her some AV nodal blocking agents to try to bring the heart rate down, probably to around 90 or so, and that might make her feel better. And we also then need to get some tests, right? We need to ask ourselves, are there some reversible causes here? Do we need to look at her thyroid, for example, or is there some infectious process in the lungs going on that we need to be concerned about? In terms of tests, I get an echo on everyone because I think it's important to understand, is this something that's causing other problems, or is this the result of other problems? So I want to get an echo to look at the left ventricular function. Is this a sign of severe mitral regurgitation? Is the left atrium big? All those sorts of things. Are there any other tests that you would definitely do on this person?
No, I think you touched base on the majority, and the point that I'd like to make, that this is one example that you were showing with a very nice and beautiful recording. It's clean, and there's no doubt in anybody's mind that this is atrial fibrillation. I just have to admit that sometimes the recording is noisy, it's hard to visualize, and that is probably the time when I might resort to additional monitoring. But for the most part, just to show you how amazing the technology has gone, I don't need an additional monitor to confirm to me the diagnosis at this point. And I think this is the most important point of the case.
Right, so at this point, I would just sort of do rate control and anticoagulation, right? I mean, I'm talking about today. And then, I would order these tests, and then we need to decide, is this paroxysmal AFib that's coming and going? Is the patient actually in it all the time and only has symptoms sometimes? These are issues that, are the topic of another conversation, but I think that giving an anticoagulant today sort of stops the clock on the most feared consequence. So we're going to go into that in a moment. And then, I just wanted to use this as an opportunity to discuss something that we don't often think about when we see this ECG, and that's lifestyle, right? We're learning more and more that there are behavioral aspects of the treatment of atrial fibrillation. And again, while we don't go into it in detail here, I generally tell my patients that if they're overweight, they should lose weight. We should evaluate them for sleep apnea because that might make our treatments easier. We want to try to reduce the amount of alcohol, and we want to have our patients exercise, at least to a moderate degree. Again, that's further discussion, but Khaldoon, is there anything else while we're on the topic that you tell your patients in terms of lifestyle?
No, I think you touched on most important points. I do reflect on the way that you and I learned in medical school about the 3 pillars of AFib management, which is stroke prevention, you alluded to, rate control, and rhythm control. And now we talk about the 4 pillars. It's part of our practice, and the 4th one being all these issues with lifestyle, because we know losing weight, addressing sleep apnea are probably as important as anything else we do to manage atrial fibrillation.
So let's talk about this woman and stroke risk, because what's interesting about atrial fibrillation is that not all individuals are at equal risk of stroke. And the therapies that we have today are quite effective at reducing the risk of stroke, but all anticoagulants carry a risk of bleeding. So we risk stratify patients for stroke using easily identifiable clinical variables. So the current guidelines recommend using something called the CHADS-VASc score. The C stands for congestive heart failure, the H for history of hypertension, the A is for age 75 years of age or older, the D is for history of diabetes, the S is for prior stroke, TIA, or thromboembolic event, the V is for vascular disease, and what we're talking about is prior MI, peripheral arterial disease, or aortic plaque. The second A gives you age 65 to 74, and the S gives you sex category, where females get 1 point. Now let me explain some things. So age greater than 75 gives you 2 points, age 65 to 74 gives you 1 point. We know that prior stroke or TIA or systemic embolization is the biggest risk factor in addition to age, which also gets you 2 points. And we now consider female gender a risk modifier. So, for example, a 64-year-old female, right, would have a CHA2DS2-VASc score of 0. A 65-year-old female would have a CHA2DS2-VASc score of 2, meaning that female gender alone doesn't get you a point. It's only used in conjunction with other risk factors. So every patient of mine with atrial fibrillation who comes in, the first thing I think about is what's their CHA2DS2-VASc score. And this is the yearly risk of thromboembolic events in those individuals. So patients with a CHA2DS2-VASc score of 0, 1, or 2 have a yearly thromboembolic rate of less than 1%, and 3 and over get you a thromboembolic rate of more than 1% per year, and patients in the highest CHA2DS2-VASc groups have stroke and embolic rates in the 3 to 5.5% range. So let's go back to this individual. She is 65 years of age, female, and has a history of hypertension. Khaldoon, any doubts that you would anticoagulate this patient?
No doubt. And this would have been a very sad missed opportunity if that patient is unfortunate to show up with a stroke as the first manifestation of AFib. Short of any active bleeding or any concerns, I think it's no-brainer. I think anticoagulation is the most reasonable next step.
So, and our guidelines would agree. So our guidelines say that for a CHA2DS2-VASc score in men, 2 points and greater, that they are recommended for oral anticoagulation. For a CHA2DS2-VASc score in women, it's 3 or more. I should point out that the novel or direct oral anticoagulants are now preferred over warfarin in the most current guidelines. And one point I really want to emphasize is that in the past, aspirin was considered a reasonable option for lower risk individuals. And aspirin has disappeared from the current guidelines because of the overwhelming data that aspirin is really not an effective stroke prevention strategy. And I think that that's a big shift that really has not necessarily promulgated down, because I see lots and lots of patients being treated with aspirin, and I see lots of patients on aspirin for unclear reasons, even when an anticoagulant is added. So Khaldoon, am I unique in that observation, or are you seeing that as well?
We see it all the time. I think for some reason aspirin makes us feel better, that there's something that's happening. In reality, it really it doesn't do the job. And in the era of DOAC, we should really not hesitate about starting the patient on the right dose. Not only just being on DOAC, but on the right dose of DOAC, because even with that, we've seen some variation. But I agree with you that aspirin is no longer considered adequate in any form or shape.
Right. So, I think that, that we have to dispel that myth. And then the other issue is that a lot of patients, maybe they were on aspirin, they get started on a DOAC, and then they get continued on both without a clear indication. So what we understand is that, that might just simply increase the bleed risk and confer no additional benefit. So I think we always need to reevaluate why that individual is on an antiplatelet therapy, and if they don't have a clear indication, particularly if they're going to be on anticoagulation, to consider discontinuing it. So I want to bring up this interesting topic. We talked about risk stratification for stroke, but we also mentioned that there are risks of anticoagulation, and there's another scoring system called HAS-BLED, and I'm not going to go into the detail, but it shows you here how that score is derived and what the bleeding risks are. And the reason I'm not going to go into detail is because of 2 reasons. Number one, this was derived for warfarin-treated patients. We don't really have excellent bleeding scores for these novel or direct oral anticoagulants. But more importantly, I don't use this score, right? I don't necessarily calculate HAS-BLED score and have that discussion, because I don't believe that this is very accurate, number one. And number two, I think that the benefits of anticoagulation are so overwhelming that I want to give all patients the opportunity to derive those benefits and only consider stopping it or alternatives like a left atrial appendage occlusion device in patients who clearly demonstrate the inability to tolerate anticoagulation because of bleeds or falls or some other reason. So Khaldoon, do you use the HAS-BLED score in your clinical practice?
It rarely comes. I don't think it's very useful as a score. What I use is common sense. Somebody that I'm concerned about current active bleeding, or somebody that even with the eye challenge exam, I see them wobbly, and maybe I'll have that discussion. Most of the use in my practice of has bled is mainly for documentation when it comes to a discussion about other alternatives to DOAC, when these clearly show some risk for bleeding and things like this, when it comes to considering other options like left atrial appendage occlusion. And if you note that you beautifully stated, the Hasbled score was designed for warfarin, so we don't have the same data for DOAC. And the irony is the same factors that increase your risk of bleeding based on the Hasbled, they're actually the same factors that increase your risk of stroke. So to me, it's a kind of a moot point, and I rarely use it at the initial discussion. Now, this is great, Rod, and this is a patient that it's a great story. She's established a diagnosis, having symptoms, but let me challenge you with another case here, because we clearly know that AFib is not one visit. That patient is probably going to see Dr. Passman for several times in their future. So 65, again, the hypertension, but this time you already have a history of atrial fibrillation. You have an established diagnosis. And now they're complaining of palpitations again, and she records this ECG. What do you do at this point?
So, again, I never trust the reading. I always want to see it with my own eyes. And you might think, well, she has a history of palpitations. She has AFib. I look at this and I see some irregularity here. And I would say she's having more atrial fibrillation and I need to up my regimen, or I need to consider an ablation. But let's wait a moment. Right? There are clear P waves that you see here. And actually, the irregularity is due to premature atrial contractions or depolarizations. This is not atrial fibrillation. This underscores the fact that not all AFib is symptomatic, and that many symptoms, even in patients with atrial fibrillation, don't occur during AFib. So, this is important, because if she had simply called me, or I heard about this individual, I would have probably brought her in, done an EKG, sent her home with a monitor, and get those results maybe 3 or 4 weeks later after she's done wearing it and sending it in. But through the use of these consumer-grade mHealth technologies, I could in real time tell her she's not having atrial fibrillation, that these are due to PACs, these are benign, and while we could give medications to try to suppress these, I find that reassurance alone might be the best treatment. Would you do anything differently?
No, I won't, and you raise a great point. These tools are great to establish the diagnosis, but also for a follow-up, and also to provide reassurance. Again, I think a lot of our patients are becoming sophisticated enough that not only they read, those systems can provide you with the actual read, but they can even challenge it if they see that, no, look, it's regular, I can see P waves. It's amazing how educated our patients are, and we underestimate their ability to do this. And providing reassurance is probably as important to them as anything else. Keep in mind that they had to live with the mystery and try to do guesswork before, and probably that used to trigger more and more anxiety and more testing, frankly. So this is great, Rod, but you mentioned about the marriage between the ability to record, which is the electrical signature that you and I need to make the diagnosis. But now with these wearable tools, specifically the bands and the watches, this is a 66-year-old man who comes to your office because he has diabetes, and his son got him this watch for Christmas, and all of a sudden he got this warning that there's something irregular about your rhythm, and if you have not been diagnosed with AFib by a physician, you might want to call Dr. Passman and check with him. What do you do with this information?
Well, I think the key here is that you should be concerned about this patient, because they are at an age and with a medical history with a higher risk of atrial fibrillation based on those factors alone, number one. Number two, the watch has picked up something irregular. And I want to make a point that the green light is not always on. It's only on certain times throughout the day when you're not moving, typically. And to see an irregular rhythm, it has to be going on more than just for a few seconds. Right? And probably even more than a few minutes. So my radar is up here, but in contrast to the patient that we spoke about that showed me the EKG, this is not atrial fibrillation until we see an ECG documentation of atrial fibrillation. So I would talk two things here. I would either explain to the patient that if they have a device that could record their ECG, and this device may have that capability, that when they get this alert next time, to put their finger on the stem of the watch and record an ECG, right, for confirmation. The other possibility is if you don't think the patient, A, has a device that can do that, or B, is not going to be capable, is that you could get some sort of medical grade monitor on that patient to see if indeed they have atrial fibrillation or some other abnormal rhythm that requires treatment. But I would not institute anticoagulation on this patient until I saw that ECG. Would you deal with this any differently?
I agree with you completely. We want that electrical signature because you still have the false negative and the false positive. And I think you probably heard about, all of us heard about the Apple Heart study. And that was basically the essence of the Apple Heart study, which is an open invitation to any Apple Watch user to use this algorithm. And they found that almost 500,000 individuals were enrolled. These are not patients, these are just consumers who happen to have the watch in the generation that would only give you the notification. It did not have the ability to record ECG, and 0.5% got the notification. Nobody would treat that, and nobody would stop at that point to start therapy. But then they got subsequent patch, etc. And now with the new generation, you can actually record. And that probably is a question on top of the minds of a lot of our audience and members in our medical community, is what to do with these random recorded saying that you have a notification. And where is the field heading with future studies that are looking not only at the recording and notification, but maybe outcomes from using these wearables?
Well, I think you raise really good points. And the Apple Heart study, to me, was important for several reasons. Number one, it's amazingly impressive how many people they enrolled online. These are not patients that were enrolled in a doctor's office. But I think it also was a relief to many of us, right? Many of us felt that when you had millions of these watches out there, that people were going to have false positives and be coming to their doctor's office, with information that was not clinically useful, was going to raise a lot of anxiety and result in a lot of unnecessary tests. The good news from my perspective was that in younger patients, right, those under 40 who were part of the Apple Heart study, were that the alert rates for irregular rhythm was very, very low, and that the older you got, the more likely you were to have an irregular rhythm notification. So that was a relief to me that we're not going to be flooded with false information. And indeed, in my practice, for the most part, when people come to me with these irregular rhythm notifications, they truly do have something going on. Even if it's not atrial fibrillation, it's some other rhythm problem, and it's rare that you get a notification in the absence of some abnormal rhythm completely. I think that the other point that you were alluding to is, that if we could use this technology to find atrial fibrillation in people who don't know they have atrial fibrillation, could we conceivably use this as a screening tool, right? To find atrial fibrillation before the stroke happens and put high-risk individuals on blood thinners, right? Will that be useful in preventing strokes? And how do we balance that versus the risks of bleeding in that population? So there's a study called Heartline, which is doing just that. It's a very large-scale trial looking at patients with increased risk of atrial fibrillation, and they'll be randomized to either the current standard of care, which is actually no digital health screening, versus getting a AF sensing smartwatch, which will continually survey for the presence of atrial fibrillation. And then when atrial fibrillation is found, the doctor will act appropriately. And I think it's a really critical study because we screen for lots of diseases, right? And we know atrial fibrillation is a disease that is highly prevalent, has significant comorbidities and outcomes. And we believe that early treatment could prevent those devastating consequences, but we've yet to prove it. So studies like Heartline and other studies that are ongoing, I think, will teach us whether these are valuable screening tools. Any other comments, Khaldoon?
No, but it's amazing how the field is evolving. As you mentioned, 500,000 individuals who participated in Apple Heart. Same thing with Heartline. This is they call them pragmatic studies. The Heartline is an open invitation to anybody who's 65 years or older that they can participate. So it's amazing how the field is evolving, and hopefully we'll gain some knowledge about not only recording, but what does that mean, and looking at some outcome data. I think the field is very promising about filling some of those gaps that we have in our knowledge about what to do with the randomly detected AFib in otherwise healthy individuals or with some risk factors.
The other intriguing part about these sorts of studies and these devices is that it allows for a sort of virtual research, right? That the days where you had to come in to your doctor's office or hospital to be part of a research study and have repeated visits to fill out forms may be gone, because we could use smartphones and electronic health records and interesting technologies to communicate with patients, enroll large numbers of patients from across the country, across the world, and communicate and get their study-specific data all virtually. So not only is this going to change how we find disease, it may actually change how we do research moving forward. So Khaldoon, we're going to do a little role playing. I am going to be the primary care doctor. You're going to be Mr. Smith, who is coming to see me for the first time. You're 65 years of age, you're male, and you have a history of high blood pressure, and you've had palpitations in the past, and your family bought you this gizmo to record your ECG moving forward. And this is a telehealth visit, and you uploaded your ECG to the electronic health record, so I'm able to see it. Are you on board for this?
Absolutely.
Okay. So hello, Mr. Smith. I'm Dr. Passman. I understand that you recorded this ECG while you were having palpitations. Is that correct?
Yeah, thank you, Dr. Passman, for seeing me today. I just moved to Chicago recently, and with all what's going on, I was hesitant to come in person, so thank you for seeing me through this video conference. I only have high blood pressure for many years, and I take medicine to treat it, but lately I've been having these episodes of palpitations, so my son got me this device, and I use my smart phone, and yeah, this is what I recorded. In general, I feel fine. It's only these random episodes when I feel my heart is fluttering in my chest, but I don't know what to do.
So how often are you having those palpitations?
I would say it depends, once or twice a week. They don't last that long. It's only, a few minutes. And, I usually go on with my life. I mean, it's not limiting me. But yeah, I would say maybe once or twice a week. Certainly got more frequent lately than before.
Tell me a little more about yourself. Are you physically active?
I like to think so. Yeah, I walk around. I climb stairs. I do my own grocery. I don't go to the gym that often. I enjoy a couple beers every night, and but that's about it. Certainly, I guess I can lose a few pounds here, but otherwise, I've been pretty active.
And any history of bleeding or liver disease or kidney disease or recent falls?
No, not that I can recall. I think I do fine. I feel I live independently, and I do okay.
So let me go over this tracing. This is a EKG tracing, and what you can see is that these spikes represent the electrical activity in the bottom portion of the heart, and you could see very clearly that the spikes are irregular, right? The normal heartbeat is regular. There's an equal distance between these spikes. And I'm able to tell your heart rate from these little lines in the background. And from this, it appears that your heart rate when you're having these episodes is about 130 beats per minute. So there are a bunch of things that we need to talk about. This is a disease called atrial fibrillation. This is very, very common, particularly as we get older, and particularly when we have other vascular risk factors like high blood pressure. And atrial fibrillation is an unusual disease. It manifests very differently in different people, and it has different consequences in different people. So in your case, you're feeling palpitations. In some individuals, they feel nothing, or they feel short of breath, or they feel lightheaded. So clearly, we need to make your symptoms better. But the most feared consequence of atrial fibrillation is that it can predispose you to stroke. What happens is, because the top portion of the heart is beating so rapidly and irregularly, blood clots can form. And those blood clots can break off and go to the brain and cause stroke. And the strokes that tend to occur in people with atrial fibrillation often are significant, are very debilitating or even life-ending, more so than strokes due to other mechanisms. So while our goal is to make you feel better, our primary goal today is to start a therapy to prevent you from having a stroke. So we're going to put you on a medication called an anticoagulant, often called a blood thinner. And we're going to put you on that blood thinner to protect you against stroke. Now, as I said, not all people with atrial fibrillation are equal. And because of your age and your history of high blood pressure, you have two risk factors for stroke. And when you have two risk factors for stroke, an anticoagulant is recommended.
See, but Dr. Passman, maybe I forgot to mention to you that I've been taking baby aspirin every day for the last 10 years, so that should be good, right?
Well, we used to think, not that long ago, that aspirin was a reasonable alternative to being on a blood thinner for lower risk individuals. But really, when we look at the data more closely, we recognize that aspirin is not an effective stroke prevention strategy and still predisposes you to bleeding. So I would recommend that you don't take an aspirin. I don't think it's going to be terribly useful in this situation, and a blood thinner would be a better option. The good news is that we had one blood thinner for 60 or 70 years, and in the last decade or so, we have now 4 new blood thinners called NOACs or DOACs, which are as effective as the old one, if not more effective, and probably safer, and it doesn't interfere with foods or other medications. You don't need to have your blood levels checked for its efficacy, and I think that would be the best choice for you.
I think I have an older brother who's on Coumadin, and he can't eat vegetables, and he has to go to the clinic to check the levels. And do I have to do this with these medications you're talking about?
Well, Coumadin is that older medication that I spoke about, but these newer medications, those NOACs or DOACs, have that one clear advantage that it doesn't really interfere with foods and you don't need to have your blood thinning level checked. So those are the preferred blood thinners for atrial fibrillation by current standards.
But Dr. Passman, here's the thing that I feel fine most days. Why should I take the blood thinner every day? Can I just take it when I don't feel good?
Well, that's an interesting question. I think that the problem is that atrial fibrillation can come and go. Atrial fibrillation can often be silent. So if we rely only on your symptoms, we are going to likely underestimate when you're in atrial fibrillation. And we don't know whether it's safe or not to only take blood thinners in response to episodes. And the current standard of care is to be on a blood thinner continuously. Now, in some cases, there are people who should be on a blood thinner but can't take it because of bleeding complications, and there are invasive approaches that might be an option for some individuals who need to be on a blood thinner yet can't take a blood thinner. So in addition to that blood thinning issue that we spoke about, which again will reduce your risk of stroke, we still want to make you feel better. And I think it's very important that we try to understand why you have atrial fibrillation and if there are any potentially reversible causes. So I'm going to ask you a bunch of questions, but I also want to make you aware that we need to do some testing for which you'll need to come to the office. We want to get some blood work. There are situations where this condition may be due to an overactive thyroid. We also want to do an ultrasound or echocardiogram of the heart so that we understand if this is a manifestation of a valve problem or a weakening of the heart muscle or an enlargement of one of the chambers that could be important. And then I think that I'm going to send you to a heart specialist, a cardiologist, to figure out whether we're going to make an effort to get you and keep you in a normal rhythm if you need that. But before I do that, I want to sort of talk about some things that you had mentioned. You mentioned that you drink a few beers per day, and you also mentioned that you could lose a few pounds and can exercise more. Let me ask you, does anyone tell you that while you're sleeping, you snore loudly or appear to stop breathing for seconds at a time? Has anyone ever mentioned that to you?
They did, unfortunately. As a matter of fact, nobody stands to stay with me in the room. My wife abandoned me and she sleeps in a different room because she said that, I snore a lot and sometimes she can see me and she gets terrified that I stop breathing occasionally. Why does this matter? I mean, how's that related?
Well, we know that there's a condition called obstructive sleep apnea, which you may have heard of. And we know that people with obstructive sleep apnea are more prone to atrial fibrillation. And if we're going to make an effort to get you and keep you in a normal rhythm, treating the sleep apnea may help us towards that shared goal. So in addition to the blood tests that we're going to do and that echocardiogram, I'm also going to get a sleep study. And then you and I should talk about lifestyle modification, the benefits of exercise, a good night's sleep, and trying to reduce your alcohol intake. And during the next visit, we'll talk about that. But for today, I want to get you on that blood thinner. I'm also going to put you on some medication to slow the heart rate down, to improve your palpitations, and then get those tests done and get you to be seen by a heart specialist. Any questions?
All right, Dr. Passman, am I going to have a heart attack or you concern me now that I need to see a cardiologist. Should I be concerned?
Well, the good news is that there are lots of effective therapies to reduce stroke risk and to control the rhythm of the heart. And I'm glad that we found this when we did. There are some people who do develop problems because they don't know they have atrial fibrillation or didn't seek medical attention. So I'm confident that because you're young and your risk factors are minimal, that we'll be able to control the situation and hopefully improve your quality of life and hopefully not have any long-term consequences.
Great. Well, thank you, Dr. Passman.
Thank you.
Yeah, thank you, Rod. I think you bring a great point as far as how to deal with all this wave of medical innovation. And the model that we are comfortable with in medical innovation is the model that relies on collaboration between physicians, scientists, and industry, identifying a need and coming up with a solution that goes through rigorous clinical trials, and then they get FDA approval. And that solution, whether it's a test or a device or a pill, gets presented to the patient by the healthcare providers. And we had a central role in the whole process. And now you see the shift in what's going on with these consumer products when you have innovative companies coming up with beautiful solutions, some medical knowledge and sometimes not that much medical knowledge, and they coming up with a beautiful product. I think you and we all had this moment when the first smartphone that has the ability to record ECG. Great tool. But sometimes they lack the simple need assessment or they lack the validation. But these devices are available to the public. They get what we call FDA clearance, which is very different than FDA approval. And now patients come to us with these devices and gadgets and gizmos, and we have to figure out a way to use it. Now, one thing you can do, you can just turn a blind eye and say, well, I don't want to deal with this, but I don't think so. I think that would be a missed opportunity to take advantage. And the model that we adopted, at least internally within our institution, is, well, let's take a pause and let's start with the basics. Let's start with a need assessment. That's what you provided to us with AFib. There's a huge need. It continues to increase. We still see the unfortunate individual who comes with a stroke and they had AFib that they didn't know about it. So I think the need is clear. Now we need to go through testing and validation. So now you have these devices. Let's talk about validation. We've conducted several studies within our institution to address this issue. Let's test these products. And we've done several studies that I'm not going to bore you with data and details, but the messages are very repetitive, are very similar when it comes to devices that are recording ECG. They work. They will do the job. Dr. Passman showed beautiful examples, and we see this all the time. And patients will adopt them. I think we're very quick to dismiss the patient's ability to use these products. That's not true. They might need some guidance at the beginning. They might need the help from a son or a brother or a friend. But once they use it, actually they use it very successfully. The automated algorithm, and that's something you heard from Rod and from myself, these automated algorithms are good, but they are not perfect. And you still, like you heard, for any clinical decisions, we really need to see that recording and have the physician overread. And let me show you some examples. Here on the left, you see clearly sinus rhythm with clear P waves with some PVCs that was misinterpreted by the cardiac system as possible atrial fibrillation. And that is not true. It's just sinus with PVCs. And the same thing with an Apple Watch, clear atrial fibrillation that for some reason was labeled as sinus rhythm. Again, great tools, but you still need to see that recording and make the right diagnosis. Do you agree with me, Rod, on that statement?
Well, I agree. The algorithms, remember, first of all, we don't really, it's not published necessarily how they work, and each company has their own proprietary algorithm. But, for the most part, it's based on, it doesn't see the atrial activity, it sees the ventricular activity. So it's based on irregularity. And so sometimes there's no rhyme or reason. I could understand why the cardia on the left may have caused AFib because the PVCs introduce irregularity. I imagine in the future algorithms will understand that when the irregularity is regular, that's probably not AFib. And conversely, on the right, it's clearly irregular, but you could see that there are periods that look relatively slow and relatively regular, and in this case, it just got it wrong. But you can't forget your medical or nursing or medical training and trust an algorithm, just as when you look at an EKG, we read it independently and we hope that the computer got it right, but we make no assumptions.
That's great. And again, as we're doing these studies and patients are adopting these technologies, all of a sudden, I remember I was not very popular among my colleagues because the concept of emailing your physician more PDFs, like Rod mentioned, you can actually share that recording. But quite frankly, that is not sustainable when you're taking care of hundreds of patients. And quite frankly, it could be dangerous when you have something that's hidden in your email and who's that patient? It comes from random email. But we actually worked in making this a bit more user-friendly. And we said, well, instead of this email exchange, why can't we just access those recordings through the cloud, bypassing the need for direct emails back and forth, which, by the way, is not considered HIPAA compliant through email. So we developed a system when our patients can record and we can access those recordings. And there's a platform now that it gives me beautiful visibility of all the recordings over time. Just to orient you, for example, this patient that you see in the green dots, they represent the normal recordings. And if you have any atrial fibrillation, it will be represented by an orange dot or red dot. Now, we don't go by the dots, obviously, and like you heard over and over, you can see a sample of that recording, and if you click on any of those recordings, it opens up the full recording. Why do I mention this? Because I think this is truly the future of telemedicine. So on the left side, this is how we conduct, for example, our AFib follow-up after atrial fibrillation ablation. You have your video conferencing technology for the virtual visit, and you have a patient who's using one of these wearables, recording over time, and they can see the normal from the abnormal, and you can see the time when that patient had her atrial fibrillation. You can see the optics of seeing the effect of before and after. Rod, I hope you shared this with me. That sometimes was not available to us when they use intermittent transtelephonic monitor when you have to click on each recording and to see what's going on. Now with one simple look, you can see the whole story of before and after. And if I have any doubt about any of these recordings, you click on it and you magnify it and you can see more. Rod, any ideas, any thoughts?
Well, this is a great example, but of course there's so many companies producing devices. Many of them have the capability of exporting a PDF. So just as patients could send in records to, we use Epic, but to MyChart, you could export a PDF of the EKG. So when you see that patient, I go into the media tab and I can see those EKGs that were sent. What you're describing, though, is perfect. And the other point I want to make is that, the kind of monitoring that we typically would do, for example, following an ablation, is have someone wear, a patch for a week or so every 6 months, for example. Well, those are just snapshots in time, right? And we know that this can be so heterogeneous when it occurs. But what you're showing me is really daily ECGs, right? The patient would have to come into your office and get this every single day. And this is invaluable information when we want to make decisions about, for example, anticoagulation or antiarrhythmic drugs. And it doesn't get any better, I think.
No, absolutely. And you mentioned a great point. I think one of the challenges is how can we integrate all this data and how can we act upon it? And The difference between AFib, what makes it a bit difficult as opposed to other consumer products, for example, for blood pressure or glucose monitoring, these devices generate numerical data. It's a number that you can easily upload to your EMR, and you just need a good partner from IT to make this happen, and you can access the recordings of blood pressure data over time. For us, like you heard, the difficulty is it's not just numeric, it's not just a black and white or yes or no. You really need to see these recordings. And that is where the difficulty comes. But I don't think we lack the technology solutions. We built one, but Dr. Passman mentioned it beautifully. You built it for one device. What about the other 5 devices that are there out of the market? I think the ability through MyChart to upload a PDF could be very valuable, but more solutions are needed to make sure that this is widely available and not just limited to one device or one particular platform of a smart device. One thing that it's important to mention, we talk about the good about this, but I mentioned it at the beginning, equal opportunity. And one thing that we keep in mind, but the wearables could be probably cheaper than implantable devices, but it's also not quite the democracy of healthcare. These devices, you show the price range that Dr. Passman showed. Sometimes they need to be coupled with a watch and a smartphone and service to make all this happen. So we're far from making this available to everybody, but I think the field is moving forward, and you just need to choose the right device for the right patient for the right need. But I'm always interested about, we think that we know it all, but sometimes patients surprise you with things that you didn't even know that you can take advantage of these devices. And these stories like this one that I'm going to share with you can teach us how actually patients are sometimes ahead of us in adopting these technologies and also get into the right diagnosis. Before I talked about the study, Rod, you led the biggest trial, which is Crystal AFib trial, and about the patients who shows up with a stroke, and you scan the carotids, there's no carotid disease, they are in sinus rhythm. Tell us about Crystal AFib and what exactly the standard of care for these patients.
So, Crystal AFib was a little ahead of its time, but I think, it asked the fundamental question. We have maybe 25% of strokes occur in patients with no clear identifiable mechanism or cause. As you mentioned, we have them on telemetry, we have scanned their carotids. We know that those patients are at increased risk of recurrent stroke, but that there's no identifiable cause that we could treat. And we also know that atrial fibrillation is a major cause of stroke. AFib can often be silent, and AFib can often be intermittent. So in Crystal AF, it was an international randomized trial of 440 patients, half of whom got an implantable cardiac monitor, and half of whom got standard of care, which was intermittent monitoring and doctor's visits. And essentially, the use of continuous monitoring found atrial fibrillation about 10 times more often than the standard of care. Now, I think, what we have learned is that the more we monitor patients, the more AFib we find. And particularly in a high-risk population where finding atrial fibrillation is going to change management, doing short-term monitor is insufficient. So what your case illustrates is that perhaps we can use wearable technology to monitor patients long-term following an event like a cryptogenic stroke to look for atrial fibrillation. Now, what's the downside? The downside here is that most of us don't wear our watches 24/7, right? And is it acceptable to be monitoring someone, 14 or 16 hours a day? Well, I would say maybe 24/7 is better, but the cost differential and the invasive nature, and as I alluded to earlier, the infrastructure that we need to implant devices is certainly not scalable. And I think that this is a great example of the potential utility of a consumer-grade electronic device to look for AFib in a high-risk individual where it would change management from an antiplatelet therapy to an anticoagulant.
Yeah, no, you stole my thunder here, but that was a lady that was referred to me because our colleagues in neurology, they're familiar with Crystal AFib, and this lady had a stroke, unfortunately, but luckily she recovered. She had embolectomy and did very well. They couldn't find a source, and they did an ambulatory monitoring through one of those traditional devices that you mentioned. So the next natural step was a referral to me to get the implantable loop based on the Crystal AFib study. Now, long and behold, in between that appointment that was made until she came to see me, she got herself a smartwatch that has the ability to record. So she comes to me, and these are all the steps, all the necessary steps. She actually got the alert, got the irregular rhythm notification, and you can see the list of those, and she went ahead and recorded. And this is the magnified version of that beautiful recording that clearly shows AFib. So I shook her hand and I told her, congratulations. I mean, thanks for coming today, but you already saved yourself an implantable device. Now, if I need those the other monitors to manage her more, sure. But as far as making a diagnosis for somebody who had a stroke of undefined source, as we call it, I don't need anything else. And again, it shows you how knowledgeable our patients are becoming. You just need to have an open mind and understand this and also use it to your advantage. Maybe we can challenge ourselves in the future. Rod, are you happy with this recording? Do you have any doubt that...
I'm actually delighted. I mean, the quality of these recordings is really quite remarkable. I mean, this is definitely, medical grade technology. But I also want to emphasize what you said. I think that a lot of times we may look at a patient and think that they're not capable of adopting these technologies. But you'd be surprised. 85% of the U.S. population owns a smartphone. I have 95-year-old patients who send me their Apple Watch tracings. So I think it would be presumptuous of us to assume that based on age or any other factor that someone's not capable of adopting this technology. And I think we have a very motivated and facile population already present and certainly emerging where this is part of their lives. So I assume in all cases that they're interested and only find out afterwards if they're not. And I sort of offer this to really almost all my patients as a rhythm doctor.
Absolutely. But again, we just need to be mindful. Digital literacy is not always at the same level, but with a little of guidance. And many of our patients, they actually have smartphones. They just used it as a phone that happened to be smart. They actually never used it of any of the smart features. But once you show them the technology and they use it, they use it beautifully. Now, we probably would fail our audience to mention that not only these technologies are evolving, and not just telemedicine, but the field in general in atrial fibrillation is moving at an unprecedented speed. Addressing lifestyle changes, the era of DOAC, all the tools that we have, not just antiarrhythmic drugs, but all the ablation technologies. I think it's a great opportunity to stay up to date in the field in general, and this is a recent review article about atrial fibrillation that probably provide a beautiful summary about all the development and some remaining unanswered questions about atrial fibrillation that would be a great source for our audience. That ends our discussion for today. Thank you again, Rod, for your insights. I enjoyed it, and I hope our audience did too. We hope you found the activity enjoyable, informative, and useful to your practice. Speaking of useful to your practice, don't miss the downloadable practice aids available in the navigation bar at the left. You can also download the presentation slides. Thank you very much for participating today.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/TWX860. This activity is supported by an educational grant from the Bristol-Myers Squibb and Pfizer Alliance. This activity is jointly provided by Medical Learning Institute Incorporated and the North American Thrombosis Forum. This activity is developed with our educational partner, PVI, Peer View Institute for Medical Education.